नमस्ते बिटिया हमेशा खुश रहो बेटी A very good morning to you all. Myself, JV'n Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine at Faculty of Homeopathic Science in JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about the thyroid disorders, especially the solitary nodule. Let's start with the last topic that we have discussed. We will continue from that topic itself. It was solitary nodule, and it is also known as toxic adenoma. We have already discussed this topic in the last lecture, but today also I want to discuss it again with you. The toxic adenoma, it is an autonomously functioning thyroid nodule that is caused by the mutation that stimulates the TSHR signaling pathway. The clinical features includes thyrotoxicosis that is usually mild, and the disorders is suggested by subnormal TSH level. The presence of thyroid nodule, which is generally large enough to be palpable. There is absence of clinical features that is suggestive of Graves' disease or any other causes of thyrotoxicosis. The diagnosis and management. The diagnosis is done by the thyroid scan that provides a definitive diagnostic test demonstrating focal uptake in hyperfunctioning nodule and diminished uptake in the remainder of the gland. The treatment is done by radioiodine ablation by iodine 131. There are various antithyroid drugs and beta blockers that can normalize thyroid function. Ultrasound guidance, repeated ethanol injections, and percutaneous radiofrequency thermal ablations to ablate hyperfunctioning nodules. Now we start with thyroid crisis. Thyroid crisis is a rare and presents as a life-threatening exacerbation of hyperthyroidism that is accompanied by fever, delirium, seizures, coma, vomiting, diarrhea, and jaundice. I will again repeat these things. Hyperthyroidism that is accompanied by fever, delirium, seizures, coma, vomiting, diarrhea, and jaundice. Even with the treatment, the mortality rate is high, that is 30%, due to the cardiac failure, arrhythmia, or hypothermia. Thyroid crisis is precipitated by acute illness, example stroke, infection, trauma, diabetic ketoacidosis with previously unrecognized or inadequately treated thyrotoxicosis. The surgery that develops shortly after subtotal thyroidectomy, and radioiodine treatment that is partially treated or untreated hyperthyroidism with iodine 131 therapy when acute irradiation damage may lead to transient rise in serum thyroid hormone levels. Now, the management of thyroid crisis. Intensive monitoring and supportive care is needed. Identification and treatment of the precipitating cause, and measures that reduces thyroid hormone synthesis. The management includes rehydration, broad-spectrum antibiotics, propranolol, sodium iodate will restore serum T3 levels to normal in 48 to 72 hours. Oral carbamazole to inhibit the synthesis of new thyroid hormone. Next, we come to myxedema. Myxedema is primary hypothyroidism in juveniles and adults that leads to myxedema. The clinical features depends on the degree of impairment of thyroid function and its duration. The insidious onset is often unnoticed. There are slow activities, lethargy, somnolence, constipation, and generalized disinterestedness. There is weight gain, hair fall, puffiness, and thickening of the skin. In lab evaluation, we evaluate for T3 and T4 levels that are low. The TSH level is very high and iodine 131 uptake is low. The antibodies, TPO antibodies, are very high, and serum cholesterol level, that is, raises above 300 mg per dl. The BMR is low. Course and prognosis. It is a slowly progressive with fluctuation in the thyroid functions, delay in instituting treatment in children that results in permanent retardation of the mental facilities. The treatment is the replacement of thyroid hormone, that is levothyroxine. Next, we come to myxedema coma. Myxedema coma results from a combination of factors like heart failure, cerebral ischemia, hypothermia, and hypothyroidism. When all these combine together, it can lead to myxedema coma, heart failure, cerebral ischemia, hypothermia, and hypothyroidism. The treatment consists of hospital admission with administration of triiodothyronine intravenous 20 microgram every 4 hours and hydrocortisone to prevent hypoadrenal crisis, and also dexamethasone. Next, we come to cretinism. The cretinism results from hypofunctioning of the thyroid gland from birth. There is iodine deficiency that is occurring in endemic goiter belts. The babies are born to hypothyroid mothers or taking antithyroid drugs during the pregnancy. The clinical features consist of the baby is lethargic by birth, the growth is retarded, and there is large protrusion of tongue. The nose is broad and flat, and the eyes are widely set. The clinical features of cretinism consist of sparse hair, dry skin, protuberant abdomen, umbilical hernia, abnormal persistence of physiological jaundice, croaky voice, constipation, somnolence, and feeding problems. As the baby grows older, the retardation of the growth and milestone becomes evident. The neurological abnormalities like deafness, spastic limbs, and coma. The ossification is usually delayed. The treatment consists of thyroid hormone replacement dosage of 10 to 15 microgram per kg with a routine estimation of T3, T4, and TSH. This is the picture of cretin child. Cretinism. There is lack of thyroxine from birth or before the birth. It can be due to lack of thyroid gland or lack of iodine in mother. It can be severe and irreparable mental defects. There can be stunted growth, as you can see in the picture, with reduced growth and functioning of many organs. So this was all about cretinism. So this concludes the lecture of our thyroid disorders. In the next lecture, we are going to start with a new chapter, that is blood disorders. This session was powered by Digital Version 2.0, JAYOTI VIDYAPEETH Women's University. I hope you are satisfied with my digital session. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. We will be meeting in the next lecture tomorrow. Thank you.